Hi everyone, my name is Colin, as I already told you, and today I'm going to be talking about the treatment of opioid use disorder. So just a little outline of what we're going to talk about. So starting off, I'll talk about opioid use, the definition that's involved, and then I'll go into some of the signs of intoxication and withdrawal, what that kind of looks like, and then I'll talk about some of the treatments. Kind of finish it up talking about two medications that are kind of confused, naloxone and naltrexone. So here are the DSM-5 criteria, kind of a long list describing opioid use disorder and kind of what's involved. So usually it's patients that are taking more than they should be, using more often. They're often trying to seek out medication, or uh, it gets involved. They're seeking out the medication, affects their daily life. They start looking to do that more than trying to be involved in their regular daily life. It just affects their daily life. So here's some information in case you're wondering more. It's just some of the guidelines. So one at the top, the American Society of Addiction Medicine, is the one that I will be more focusing on today. That's where I got most of my information. There's some other ones too. Slide, please. Okay, so here are some of the signs of intoxication. So one of the big signs that people always hear about are pinpoint pupils of the eye. And so you can see in the bottom picture, the bottom right eye, it's that really small picture. Whereas I'll talk about in the next slide with withdrawal, you're going to get the opposite. You're going to have the really large pupil. So some of the other signs of intoxication, so it's going to be slow breathing, drowsiness, slurred speech, almost kind of drunken, but just generally sedated, and just kind of in a stupor. So then, yeah, moving on to some of the withdrawal symptoms. So some of the opposites. So like I said, mydriasis, which is also called just the dilation of the pupil. They're not going to be feeling good. They're going to have tachycardia. Tearing of the eye is another common effect. Goosebumps, some abdominal cramps, so just generally nauseous, not feeling well. Their body's reacting very poorly to being off the medication. As a weird side note, you may see there's a baby in the top right corner. I guess that's from, there's a movie called Trainspotting, and there's a scene, and that's where this picture came from. Kind of a weird side note. So anyway, next slide, please. Okay, so the initial assessment. So things you're going to want to look for in these patients. If they have any chronic diseases, like hepatitis, HIV, tuberculosis, pregnancy is another big one with certain medications. I'll talk about later. You don't want to use in pregnancy. Okay. Okay. Sorry about that. So for initially, I'll just go back. So like things you want to look for are going to be some chronic diseases like HIV, hepatitis, tuberculosis. Some laboratory values, you're going to want to get a complete blood assessment. You're going to want to look at your liver function tests. And then, like I said, the Hep C and HIV. Any other things you want to look at outside of laboratory values? Social, behavioral issues, see kind of what their family situations like, if they have any support support at home or support within their friend groups. And then certain medications, so sedatives like benzodiazepines, any tobacco products, alcohol, marijuana, are all things that you want to address. So then for assessing, so there's an assessment scale for the withdrawal. It's called the Clinical Opioid Withdrawal Scale. It's often called COWS, so if you ever hear that term, that's what they're talking about. And it's an 11-point scale that addresses many of the common side effects that are involved with withdrawal symptoms. And then there's a scoring system. In the next few slides, I'll show you the actual ratings, and they're objective ratings, so you don't have to worry about guessing if it should be one thing or another. So here's the first half of it. So the pulse rate, any GI symptoms, tremor, sweating, restlessness, and yawning. And so they're all on a 0 to 4, 0 to 5 scale. You kind of just address this, and then on the next set, there's a couple more. So like pupils, anxiety, goose flesh, which is just goosebumps, any bone or joint aches, and then any tearing or runny nose. And then you kind of assess all those, you add it up, and then you can kind of address where these patients are in terms of symptoms, where you should go with therapy. So to start off, some non-pharmacological therapy, so just stuff to look at. Any cognitive behavioral therapy, any family therapy, maybe looking into self-help groups, making sure they have positive support within their family or within their friend group. So then I'm going to start talking about the pharmacotherapy options. So the main 4 options are methadone, buprenorphine, naltrexone, and naloxone. One of those is a little bit different, but I'll get into that later. So for who can prescribe these, so methadone has to come from an opioid treatment program, which are usually in a facility. Usually the medication isn't really dispensed outwards. And there's a lot of federal laws involved in this. Buprenorphine, on the other hand, for prescribers who want to prescribe this, they have to go through a series of trainings. They have to go through the Data 2000 waiver. They actually get, so most doctors have DEA numbers to prescribe buprenorphine. You have to get an ex-DEA number, so it's a separate DEA number that says that you can prescribe these medications. And so normally these are, they call them office-based opioid treatment facilities, and these are usually outpatient. And then naltrexone is any clinician with prescribing authority. So now I'll be talking about the different medications because they're on different levels in terms of what they're doing. So on this slide, you'll see at the top you have a full agonist, partial agonist, and then an antagonist and an inverse agonist. And so with these medications, you'll get different rates of how pretty much to what effect they will have. So the antagonist, whatever kind of metabolic, like base, whatever rate that you're normally at is just going to stay there. So you're blocking the effect of potentially anything increasing or decreasing the effect, the normal effect of the body. Whereas a partial agonist, you're causing a positive effect, but you can only reach a certain threshold. So it's got kind of a ceiling, whereas a full agonist, you're going to have the maximum effect. This is so these are going to be mostly your opioid medications. And yeah, so if you want to hit it once more. So then these medications are showing at the different levels. So methadone is going to be full agonist. It has the strongest effect. Buprenorphine is a partial agonist. And naloxone and naltrexone are both antagonist medications, and I'll get into that more. So starting off with methadone. So normally methadone is given in, like I said, in clinics. It's given as a liquid, and normally what they'll do with this medication is the term is that pharmacy uses is QS, but it just means that they'll fill it up to a certain volume so that the patients within the clinic don't know how much is actually in there, and they can't tell by just the volume. So only the clinicians really know exactly how much is in there. So the background on methadone. So like I talked about, it's a full agonist, so it's going to have a very strong effect in terms of the opioid receptor. It's not to be used in patients with respiratory distress because it can precipitate that. So like asthma patients, so patients with any lung diseases. And like I said, so opioid treatment programs, they have to they usually supervise the dosing of methadone only with continued observation and patients who are adherent, they give them outpatient medications. And so some things to avoid use in, like I said, respiratory depression, the lung diseases, and then paralytic ileus is a bowel disorder where the bowel doesn't work correctly and isn't moving stuff through in a normal manner. So it's kind of a dysfunction. It's essentially a slower movement of the bowel. So normally, with methadone, it's initiated at 30 milligrams. Per federal law, that's the maximum you can give, or 40 milligrams within the first 2 weeks. It's got a really long half-life, so usually this is only dosed once a day. Normal doses, 60 to 120. And most of the side effects are dose-related, so one of the major ones to watch out for is PTSD prolongation. And so here is the map of billings, and I have two methadone treatment facilities. In the top right corner, we have ideal options. And down in the bottom left, we have the community services. Usually 2 methadone clinics within the Okay, so then moving on to buprenorphine. So kind of, if you're going to switch to it, normally you want a low dose of methadone because methadone has much stronger effects. So if you're going to try and switch to buprenorphine, which is quite strong, you might cause some withdrawal symptoms if you make the transition. One thing to know for buprenorphine is you have to be experiencing some sort of withdrawal in order to get started on it. And so normally this is assessed on the CAL score, and it's considered to be a score of 12 or greater. So continuing on the therapy, they'll increase the dose by 4 to 8 milligrams. Normally patients, it's 12 to 16, it can be up to 24 or 32 depending on the treatment. Some side effects, they might get constipation, some fluid retention, maybe some sleep disturbances. And then while it is much harder to abuse buprenorphine because it has a ceiling effect, there is a potential for diversion. So normally they'll do urine drug screens, kind of check to see if there's any metabolites from buprenorphine within the urine. They can also do pill counts, or if they really don't trust them, they can do observed dosing, where they actually make them take it from the prescriber. So like I said, starting on buprenorphine, usually they'll do an initial dose of 2 to 4 milligrams, and then observe them for the next hour. If they're doing better, they can give them additional doses. So usually we'll give them 2 or 3 to start out. The usual dose, like I was saying, can be anywhere from 4 to 16. And then, like I said, because it's a partial agonist, so it can only reach a certain threshold. It has a ceiling effect in terms of effectiveness. So you only get to a certain limit, or a certain maximum amount, based on how many you're giving. And what's interesting is there's a new injection that recently got approved. It's not on the market yet, but it's called Sublocade, and it's a long-acting buprenorphine injection. So to start on it, you'll have to be on the oral one for 7 days, and it delivers a sustained release over the month. But that'll last an entire month. So that'll be interesting to see how that kind of changes prescribing, because Suboxone is pretty big medication. So then the next 2 medications. So these are both antagonists. So say that you're in a facility and the doctor says, you need to save this patient, they're overdosing. And there's 2 vials, there's naltrexone and naloxone. You don't know which one to grab. And so say you grab the wrong one and then the patient's still overdosing and, you know, they're in, they're in a critical need. So you can go to the next slide. So the way to remember it is that naloxone, which has 2 O's in it, is for opioid overdose. So naloxone, while naltrexone is used for long-term therapy, naloxone is only used in critical situations of patients that are overdosing, and it's to get them out of that. It's to get them out of that withdrawal of overdose. So naltrexone is an opioid antagonist, like I discussed. It can be given orally, 25 milligrams a day, and then titrate up from there. There's also a long-acting injection, which can be given every 4 weeks. It's important to note that you can't be giving other opioid medications with naltrexone because opioid medications are going to be antagonists and naltrexone is an antagonist. So if you're trying to give these together, you're essentially negating them. And so patients may end up taking more opioids or, say, heroin and try and counteract that negative effect of the medication and end up going to an extreme and taking too much medication and causing going into an overdose situation. So naloxone is also an antagonist, but like I said, it's only used in overdose situations. On the right is a picture of one of the forms of it. So naloxone can be given many different ways. It can be given IV, it can be given IM, it can be given subcutaneous or intranasal. And so on the right is the intranasal form. So what you do is you have your 2 fingers and you push the plunger up into somebody's nose and it should get them out of it. Usually these are given 2 at a time. And with naloxone, usually if they don't react to the first dose that you give them, you wait a few minutes and then you give them another dose. This can be up to a maximum of 10 grams. Usually the dose is low, it's like 0.4 milligrams. And so then there's a combination product with buprenorphine and naloxone. And so why would this make sense? Because you have buprenorphine, which is a partial agonist, and naloxone, which is an antagonist. So you're going to just be negating the effects. But the thing is, with naloxone, it's only good when it's injected. So if you try and give it orally, it's not going to get absorbed. So essentially all you're going to be getting is the buprenorphine. But if patients, say, try to crush it up or they try and melt the films, which is what the Suboxone boxes are, the films. If they try and melt it and inject it, then they're going to be getting the naloxone, and that's going to be countering any opiate effects that they might be trying to receive from the buprenorphine. So that's why these medications come together. Orally, you're not going to get any of the naloxone, you're just going to get the buprenorphine, and it helps for patients that are going to try and abuse these medications. So then, you've got a bunch of medications, so kind of what do you choose? So with methadone, these are going to be for patients who are on extremely high doses of opioid medications, or who have been abusing heroin and other illicit drugs for a long period of time. These are often going to be your most severe patients who have the highest need for these kind of withdrawal or treatment medications. And then buprenorphine is going to be kind of the next step down. It's better because it can be given outpatient. So you can dose it for weeks at a time. And then it's got the Suboxone, which is often the form that they give it in, which can help avoid overdose and avoid abuse potential of these medications. And then naltrexone is going to be your kind of lower tier, where these are patients who have been off medication for a long time. Usually a shorter use. So not as long a history or a lower dose of opioid medication used. It's also used in alcohol use disorder. You want to make sure that the risk for the patients who are getting this medication are low, because, like I said earlier, if you're giving an antagonist and they're going to say take some opioid prescription medications, they're going to have to essentially outdo the negative effects of the naltrexone. Then they'll end up taking way too much. So then pain management. So normally you're going to try and start therapy with non-narcotic medication. So your Tylenol, your Motrin, anything over the counter usually. You can also try and give some tricyclic antidepressants. So the tricyclics, your SNRIs, and then for more neuropathic pain, you could give gabapentin and pregabalin. If you're going to try and give, or if you have patients on methadone, they should really consult a pain specialist because of usually how high their doses are for methadone. And if they're also needing medications for pain, whereas methadone does provide some pain effect. They should really be consulted and address that issue with somebody who's qualified for that. And then, so the treatment medications, buprenorphine and methadone, they can be used in patients who are not currently receiving treatment for opioid use disorder. And so then continuing with pain management. So methadone can be prescribed opioids while the methadone patients can be prescribed opioids while they're on methadone. But like I said earlier, you'd really rather prefer these patients to get pain specialists. And they'll likely have to increase the methadone dose if they wanted to use that as a pain effect from once a day to multiple times a day to get any sort of pain relief. And then for buprenorphine, you can increase the dose for patients who are taking it for acute treatment of pain, so if it's just a couple of days. But if they're going to need higher control, like if they're having surgery, usually they recommend stopping it and starting it on something that's more of a full opioid agonist. So then in naltrexone, so patients making naltrexone, like I talked about earlier, this is an antagonist, so you want to avoid opioids because of the negative effects that naltrexone is going to have on the receptor. For mild pain, they recommend NSAIDs, so ketorolac or ibuprofen, medications like that. And then if they have surgery, they recommend discontinuing the oral version of naltrexone for 72 hours. And if they're getting a long-acting, likely they would want to schedule the surgery 30 days out from their last injection. And then if they're going to restart, they want to wait 7 to 10 days after their last dose of opioid treatment. So then in pregnancy, methadone is often the standard. Buprenorphine can be used, but they'd rather use it on patients who are going to be adherent, who are going to be able to follow up on office visits and stuff like that. And so they don't recommend using naltrexone and naloxone because they're antagonists. They could cause withdrawal, and that could lead to a spontaneous abortion in pregnant patients. And then here are some of my references. So, does anybody have any questions?